Hello friends, I am Dr. Sourabh Patwardhan from Nandadeep Eye Hospital PG Teaching Institute and FECO SICS Training Center, Sangli, Maharashtra, India. In our center, we have a lot of teaching activities which includes hands-on training as well. In this video, I'll be speaking about a case of developmental cataract and child had a posterior capsular plaque. So this is an 8-year-old child who presented with unilateral cataract. The parents noticed some whitish opacity and that's why they came for examination, and we found the child has a developmental cataract and it has to be removed and replaced with PCIL. And now regarding the IL power calculation for 8-year-old, I will use almost symmetropic IL power, maybe reduce it by 0.5. Now I am going to use the 2-incision push-pull technique described by Dr. K. Nishchal. You can see I made 2 incisions and then I start capsular axis from both of them and then join it together. This particular technique helps in keeping the capsular axis size to the desired, because in pediatric cataract we sometimes tend to overshoot and tend to have a larger axis because of the elastic capsule and sclera which stretches the capsule out. I use always the OVD of 1.8% hyaluronate, which is heavy and puts pressure on the anterior capsule, avoiding the extension of the capsular axis. Good hydrodissection is needed because this is a very soft cataract, and I'm not going to use phaco probe. In fact, I'm going to use coaxial eye probe to just remove all the soft lens matter. Phaco probe will do it little bit quicker. It's fine to use coaxial eye or bimanual eye as well, because you can use the same to remove the cortex as well. And cortex cleaning has to be very meticulous in these pediatric cases. You should not leave any cortex behind because it leads to inflammation in the post-operative period. So as I removed the cortex, I realized that there is a posterior capsular plaque there which is quite adherent. So I am using a blunt end Sinski to find if I can find some plane somewhere, and here I found it. So I tried to open it slowly, and it's important to have filled anterior chamber, but don't make it too tight. If you make it too tight, the posterior capsule goes back and makes the things little bit more difficult. I'm using 1.8% hyaluronate again here. So after making the plane, I'm going to use microcapsular axis forceps with a blunt end to hold it and then pull it centrally. It's always important to pull it centrally and not towards the incision. And I'm trying to be as gentle as possible, holding the plaque closer to the capsule so there is no undue stretch on the posterior capsule here. So always pull the plaque centrally. And now I realize that though almost all the plaque is removed, there is a small rent, or there is a small tear in the posterior capsule. So I decided to complete the posterior capsular axis here. Anterior hyaloid is still intact, but I decided to do limited anterior vitrectomy here because this is a 8-year-old child. Though of course I generally do it up to 5 years of age, but here because the anterior hyaloid was exposed and I was little unsure about whether it is intact or not, I decided to do limited anterior vitrectomy to avoid any vitreous prolapse later on. This is the way to implant the IOL. This is a hydrophobic single piece IOL. I placed a Sinski underneath the IOL so that it doesn't jump into the bag and may cause increase in the tear of the posterior capsular axis. So first it unfolds in the anterior chamber and then I gently nudge both the haptics in the bag. Again, the OVD used here is 1.8% hyaluronate. It helps in maintaining space. At the same time, it can be removed very quickly while we are aspirating. So I am using the vitrectomy probe itself to aspirate out the OVD, which is hyaluronate here. And then to remove the OVD from the anterior part of the vitreous, I use the cutter and remove OVD from the anterior part and remove if there is any vitreous there. Before I close, I am going to inject a little bit of myocol to constrict the pupil, and then diluted triamcinolone to watch out for any vitreous strand if I have missed, and also it will reduce the inflammation in the post-operative period. So this patient is going to do well. For 8-year-old, I do not always suture the incision, and if you have noted, I have made a posterior limbar or slightly scleral incision so that it heals well. So this is it. Anterior capsular excess, posterior capsular excess margin, and a great outcome is expected. Patient will require some amblyopia management because this is a unilateral cataract and cataract was noted a little late. So we'll continue to do that. Thank you so much for watching.